عشان يعني نقدر نبقى لسه في كل الاكتيفيتي. This is the pulmonary hypertension session. It's my honor and pleasure to co-chair this session with my colleagues and friends, الأستاذ الدكتورة سميحة أبو بكر والأستاذ الدكتور عبد الصادق العرج. It's really an honor and pleasure to introduce a pioneer and an eminent figure of pulmonary hypertension in our area, دكتور مجدي كما يحب أن ينادى، دكتور مجدي إدريس. دكتور مجدي إدريس زميلنا من المملكة العربية السعودية، هو الهيد اوف ريسبيريتوري ميديسين ديبارتمنت في الميليتري فورس هوسبيتال في الرياض. And he's also the head of the advisory group of pulmonary hypertension, one of the groups اللي تحت السعودي thoracic society. أنا أحب بعد كده أتكلم بالعربي. أنا بشكر صديقنا الدكتور مجدي إن هو دايما في كل مؤتمراتنا في مصر هو whatever الكوميتمنت بتاعته ما بين كندا وما بين المملكة دايما بيكون حاضر من لنا سبورت. بشكره جدا انه في كل الميتينجز بتاع البلمونري هايبرتنشن اللي في الريجن هو مسؤول عنها بيدعو كتير قوي من الدكاترة المصريين وبيسبورت دم. بشكره على آرائه الجميلة في الفيسبوك. أنا سعيد إنك أنت معانا النهارده يا دكتور مجدي. دكتور مجدي هيكلمنا على now and the future في المانجمنت أو situation of pulmonary hypertension.
Assalamu alaikum wa rahmatullah. Thank you very much, Dr. Adil, for this wonderful introduction. It's always an honor, really an honor for me to be part of this very prestigious meeting with the names such as Adil Khattab and Tariq Safwat and others. I really feel humble by being part of this wonderful group. And it's always an honor and nice to be here in Egypt. I know that I've been assigned to stay in the airport area, so I'm not going outside the airport. Thanks for my friend, Dr. Tariq Safwat. So I'm not going to be leaving the airport area, but that's fine because I'm leaving tomorrow morning. But it's always a pleasure to be here, and thank you very much for the introduction. The pulmonary hypertension, which is a great subject, I think, it's part of respiratory medicine that's been developing at very faster rate compared to many other branch of respiratory medicine. And let me tell you, for example, if you look at the randomized controlled trials that's done in pulmonary hypertension for the last 6 or 7 years, it's about 24 randomized clinical trials. And you wouldn't find this in any kind of part of very, very specialized field of medicine. So before I start, this is just like my disclosure slides. There's nothing that I need to announce for this particular lecture. So what is pulmonary hypertension and how we classify pulmonary hypertension at the moment? Now, based on the World Health Organization, we no longer talk about primary and secondary. Now we have groups, so we talk about group 1, 2, 3, 4, or 5. And group 1 pulmonary hypertension is where, if you like, most of the interest belong, because this is a disease which has a lot of similarity with cancer, for example. It leads to proliferation of the cells and obstruction of the vessel, and we call that pulmonary arterial hypertension. The idiopathic form is part of it, which we used to call primary pulmonary hypertension. Now, the most common cause of pulmonary hypertension is group 2 disease, which is PH due to left heart conditions. And then you have the group 3, which is PH due to lung disease and or hypoxia. Group 4, which is the chronic thromboembolic pulmonary hypertension. And group 5 is basically the miscellaneous group. Nevertheless, whatever group you look at, the definition is the same. It is mean pulmonary artery pressure of equal or more than 25 millimeter of mercury as measured by right heart cath. So once you get that number, so you can say my patient has pulmonary hypertension, and now it's my job to classify the patient into one of these 5 slides. Now, pulmonary hypertension in general is a fatal disease. And if you look at the historical data back on the 80s, you can see that it's kind of 1-year survival is about 60%, 3-year survival is about 30%. It's a horrible disease. It's as bad as cancer. Now, with the modern therapy until recently, we managed to improve that significantly. We almost doubled the survival. If you look at now, the 1-year survival is about 90%, the 3-year survival is 60%. That's pretty good, but it's definitely not good enough, because still you have a disease that 40% of your patient will die by 3 years. And we know that at the moment, the mortality in general is about 10% of year per patient. So it is still very, very bad disease, and we need to do better in order to optimize our care. So pulmonary hypertension today, people try to target certain biological pathway, and most of our pathway at the moment, as per today, concentrating on 3 pathway. The endothelin pathway, that trying to inhibit the endothelin receptor that present on the smooth muscle cells, that will lead to vasodilatation and inhibition of the proliferation. We have the nitric oxide pathway trying to maintain cyclic GMP that again cause vasodilatation and proliferation inhibition, and the prostacyclin pathway, again similar to nitric oxide but work on the cyclic AMP this time. So these are where we've been working extensively for the last, I'll say, decade or 2. Now, very recently, we have some improvement in these same areas. We're still working on the 3 areas. And the first improvement, I'll say, is the now availability of macitentan drug. Now, macitentan, if you remember the old drug, bosentan, that used to be available, macitentan is from the same group. And the Seraphim study that was basically published last year was a landmark study. We're still using the same drug, but this drug seems to be more potent, more effective when it compared to the previous drugs. And this was one of the longest and biggest clinical trial in pulmonary hypertension, and it was driven by event of mortality morbidity. So the primary endpoint for the Seraphim study was time for treatment initiation to the first morbidity mortality. So this was looking at what we really care of, the mortality and morbidity, not only for 6-minute walk distance or certain hemodynamic improvement. So in the Seraphim study, they look at macitentan 10 milligram, and that's what's important because now this is the approved dose versus 3 milligram versus placebo, and they continued as long as it takes to get 285 event of mortality morbidity. So this was there was no pre-specified time for the study. They have to continue until they get that number. And very nicely, macitentan showed that it decreased mortality morbidity by further 45%. So this was an amazing study showing that here we go. Now we have a drug that further should improve mortality morbidity. And even if you use macitentan on patient who received other drugs such as sildenafil, Viagra, or prostacyclin, there was still about 40% improvement in mortality morbidity. So here we go. Nowadays we have this drug in the endothelin pathway that may give further hope for our patient. What about the other pathway? We still have a new drug in this pathway, which is the nitric oxide pathway, and this drug called riociguat. Now, just like, let me refresh your memory, what we usually have, we have the nitric oxide that come from basically L-arginine. It stimulates the cyclic GMP. The cyclic guanylate cyclase enzyme to convert GTP to cyclic GMP. Now, but as you know, that in pulmonary hypertension, you have very diseased endothelial cells. So we have very little nitric oxide, and so we have very little cyclic GMP. Nevertheless, we used to use sildenafil or Viagra, trying to keep the little cyclic GMP what we have. Now with this new drug, you don't need nitric oxide, because this drug, although it works on nitric oxide, but it can directly stimulate the cyclic guanylyl cyclase enzyme to form cyclic GMP. Very interesting. And this drug has been tested in two subgroups, in group 1, the pulmonary arterial hypertension, and in group 4, the CTIF patient. It was the first drug that was used in the CTIF patient. And the patent study, again in the New England by Hussein Ghofrani from Germany, showed that riociguat, when it's used in a randomized controlled trial versus placebo, trying to reach a dose of 2.5 milligram TID, showed significant improvement in the exercise capacity, the 6-minute walk distance in those patients. Not only that, when you look at other hemodynamics such as pulmonary vascular resistance, the cardiac output, the pro-BNP, they all improved. So this looks like another good drug that we might have. The side effect was a bit ingredient. It was a little bit of hypotension. None of them were severe enough to stop the drug, but we have kind of those attacks of hemoptysis that still people are watching what is going on, why those people get hemoptysis. Nevertheless, that happened in less than 1% of the case, and riociguat is now approved for pulmonary arterial hypertension. But as I told you, the drug is also used in CTIF patient, and it's the only drug that can use in chronic thromboembolic, and this was the CHEST study, again, in the New England Journal of Medicine by the same author, R.D. Ghofrani from Germany, and again showed for the first time that now we do have a drug that improve the outcome of CTIF patient who cannot go for surgery, who are not eligible to go for endarterectomy, again with improvement of all the secondary endpoint. And it was a breakthrough in this field that now we have another drug that's worked there. Guess what? We still have a third drug coming to the market called the selexipag, and selexipag is now working on the prostacyclin pathway. It is not prostacyclin, it is a prostacyclin analog that stimulate prostacyclin receptors. And a few years ago, a phase 2 study looked at the selexipag versus placebo, showed that selexipag did drop significantly the pulmonary vascular resistance in those patients. So that was an amazing things happen. But, and also improve the hemodynamics. And now we have phase 3 trial. This is still unpublished data, very, very new studies that Actelion announced a few weeks ago. Phase 3 trial look at selexipag in a very similar way to macitentan in an event-driven study, going for as long it takes to get the number, and selexipag improve mortality morbidity by about 40%. Again, extremely good news. So now we have 3 new drugs, each drug in the old category, but they are just like enriching our options in treating those patients. But what we are looking for the future, because just like, as I told you, we are getting better, we are improving our services and our prognosis for the disease, but still this is not the end. So what else we can do in future? One thing we can do in future is to target other signaling pathway apart from the prostacyclin, nitric oxide, and prostacyclin. And now we start targeting other pathways such as many, if you like, growth factor upregulation, trying to inhibit, for example, platelet-derived growth factor and other growth factor, which is, if you like to think about it, is very cancer-like mechanism of treatment, and using other kind of still experimental, but targeting, for example, the VIP, the vasointestinal peptide pathway, trying to target the disease and control the disease by many pathways. So if you look at it, when we look at this anti-cancer strategy, for example, it makes sense because now we know that in the vast majority of those patients, those vessels are not vasoconstricting actually. Those vessels are, the cells are proliferating and they don't die. So the vessel getting occluded and not simply vasoconstricted. And this is because of the imbalance between cell proliferation and programmed cell death or the apoptosis. And when you look at phenotypically altered nuclei at the histopathology, and you can find staining for many, many growth factors. So it is a proliferative or mitotic disease that the cells, for some reason, don't die. So the first study that was trying to address this anti-cancer strategy was the EMPRESS study. And the EMPRESS study, they used imatinib, and imatinib is a tyrosine kinase inhibitors that is used for leukemias, mainly, trying to target those patients. And for the first time, they used this drug very nicely in very severe patients who are already on at least 2 drugs. So now you are using anti-cancer drug for patients who are at least on 2 drugs. And guess what? Imatinib showed significant improvement in the 6-minute walk distance. That was the primary endpoint. But more importantly, it showed significant drop in the pulmonary vascular resistance. And let me stop you here for a second. Why imatinib should cause that drop in PVR on patients who are already on 2 drugs? The only explanation that new vessels or the old vessel get opened, those blocked vessels, they now opened up because this drug is not vasodilator in any way. So the only mechanism that imatinib can work is to open a blocked vessels by either inhibiting proliferation or improving apoptosis. Cardiac output improve, right atrial pressure improve, and the pressure drop. The only problem with imatinib that put everybody off is the side effect. That was cerebral bleeding and a lot of other side effects. So the author believed that although this drug worked on the hemodynamics, because of the side effect and because of the patient's quality of life, that was a negative study. So, but that should not put us off because I think we should look at different dosing, different drug, but it seemed that this strategy might indeed work. And the other pathway that we're talking about is this basically VIP or the vasointestinal peptide that now we have animal data to show that if you have basically mouse or mice or rat and you knock off the genes for VIP. So now there is no more VIP pathway in this rat. What happened? The right ventricle dilate and the RV in diastolic pressure goes up, as it happened exactly in pulmonary hypertension. And because of that, now there is some new studies still on animal to show that by giving our patients VIP, we may able to reverse this process as well. That's still very early, but it's just a new pathway that we are talking about. What else in the future, apart from a newer drug? I think now we learn that we might need to change our strategy, not only changing the drug or having a new drug, but our strategy should change. And one of the changes that now we talk about is early combination treatment. And it makes a lot of sense. We know that in pulmonary arterial hypertension patients, they have many, many active pathways. And it makes a lot of sense to start blocking these pathways way at the beginning. And I showed you 2 studies already, the serafin with the macitentan, when macitentan was added to other drugs such as sildenafil or prostacyclin, there was about 40% improvement, and riociguat in a patent and a chest study when it was also added to other drug, it make effect. But again, very new study, still unpublished, that was I think 10 days ago, the Ambition study looking at upfront combination between a drug called tadalafil, which is the Cialis, which is very similar to sildenafil, and ambrisentan, which is very similar to basically bosentan. When you use it as upfront combination, there was significant, about 50% improvement in the mortality morbidity. So now we have the first study to show that upfront combination, you don't need to wait until the patient deteriorate to start a new drug. From the beginning, you start 2 drugs at the same time. And I think, although still the guideline talk about sequential combination therapy, in the future, we're going to talk about upfront combination treatment. And lastly, it's about phenotyping of pulmonary arterial hypertension. Now, all of us, we know a lot about phenotyping of asthma and COPD, and we now start realizing that asthmatic patients are not the same, and COPD patients are not the same. And the very nice study that was just released a few months ago in the New England about using anti-interleukin 5 in asthmatic patient, that it only works in eosinophilic asthma. So if you use this drug in any other phenotype of asthma, it will not work. It will work only in eosinophilic asthma. So maybe we start thinking similarly in pulmonary arterial hypertension. We need to look at those phenotypes and then modify our treatment accordingly. This is our data from Saudi Arabia. This is about 110 patients of group 1. Those are congenital heart disease. This was idiopathic. This is not very clear. That was the portal hypertension, pulmonary hypertension, connective tissue diseases. Now, those all groups belong to group 1. But this is the survival. Look at the difference in survival between the congenital heart disease PAH and the portal pulmonary arterial PAH. Those are not similar diseases. The outcome is very different. Despite that, we still lump them under group 1 disease. So we start thinking that maybe we should do something different, and we should start looking at different phenotype. For example, disease phenotype, as I showed you, we know that, for example, connective tissue diseases do very bad compared to the congenital heart disease. And we know that portal pulmonary hypertension do very bad compared to idiopathic. So we need to classify them. What about vasoreactivity? Yes, we know that those patients who have a lot of vasoreactivity do much better than those who have fixed obstruction. Mitotic phenotype, we have those who have mainly proliferation versus those who have no proliferation but inhibition of apoptosis, that the cell don't die. And maybe we need to start looking at those phenotypes in future. So my take-home message to you is pulmonary hypertension is still a very interesting disease. And I think it's fascinating. It's the first disease that linked respirologists to the cardiologists. As a matter of fact, before pulmonary hypertension, we as respirologists used to hate cardiologists, right? Because we think that they have more money and they have more prestigious, they have better car. But nowadays we have a disease that link the two together. Unfortunately, it is still a very bad killer. And we know that we are getting better. We almost doubled the survival, but still, that's not the end of the road. We should improve the situation far better than this. I did show you data on the new drugs, the macitentan, the rivastigmine, and the selexipag that will be coming to the market. Actually, the first 2 drugs are already approved and they are in the market, and selexipag will be probably in the market within a year or so. We know that newer pathways such as targeting cell proliferation by using anti-cancer drug does hold a lot of basically of really promise. Combination strategy now is evolving and now will probably become a standard of care, especially when the prices goes down. And phenotyping of the disease is a new thought that more and more people are talking about it, and hopefully it will improve our outcome further on. Now, I'll stop here, and this is our next meeting. If you'd like to know more about basically pulmonary hypertension, it will be in Abu Dhabi between 9 to 11 of April. And as always, any bronchology society member is welcome to come for free. Thank you very much for your attention.
Thank you, Professor Majdi Idris, for very elegant talk, actually. And now we open the discussion if anybody has any question.
I have one question here.
لو سمحتك بالنسبة للدراجز اللي احنا بنعالج بيها الانترستيشال لانج ديزيز، هل ليها امباكت على البلمونر هايبرتنشن ولا لا؟ يعني هل في لينك ان مثلا في انتر اكشن زي الاميوران مثلا؟
Sure. Thank you very much. This is a very nice question. Now, the question about interstitial lung disease and pulmonary hypertension. Now, we know that interstitial lung disease can cause pulmonary hypertension simply because of the hypoxia, the lung damage, etc. Now, the old drugs such as steroid, Imuran, definitely has no effect on the pulmonary hypertension. But now, those new drugs that come for the interstitial lung disease that are the tyrosine kinase inhibitor, the new study in the New England basically a few months ago, that now the tyrosine kinase inhibitor might work in interstitial lung disease, and I showed you data that they might work in pulmonary arterial hypertension. And both of these drugs work on inhibition of the cell proliferation. Of course, in the interstitial lung disease, you are trying to inhibit the fibroblast proliferation, but you are inhibiting other growth factors as well. So maybe in future we can use one drug for both conditions, because the mechanism is, yes, we have to inhibit the cell proliferation. And I think this basically tyrosine kinase inhibitor data in interstitial lung disease is an amazing, that it was the first drug ever showed that it can slow down a little bit the progression of the disease and improve the quality of life. So it may be. Yes, please, of course.
I know you don't like this term. We have a problem with hepatitis CV in Egypt.
Right.
And it's a major problem, the portopulmonary hypertension. And you know the Bosentan, the endothelin receptor antagonists are indicated in cirrhotic livers.
Right.
So what would be your advice concerning our poor financial situation that we cannot afford paying for these extravagant, extremely expensive medications? What would be your take-home message for the treatment of these patients, apart from liver transplant, etc.?
Sure.
What would you recommend?
Yeah, thank you very much. I mean, this is very fascinating disease. And just like the question, do we have the data in Egypt about the prevalence of the portopulmonary hypertension? Do we have, anybody did some kind of, any thought of what's the percentage or the basically prevalence? We don't have data on that. Because I think if you look at the data, of course, most of the studies treated idiopathic pulmonary arterial hypertension and the congenital heart disease. So we have very, very few studies targeting specifically the portopulmonary hypertension. But because it is under group 1, people treating it the same. Now, even looking at bosentan, for example, in somebody who's having portopulmonary hypertension, there is a few case reports showing that bosentan is safe. Of course, you need to monitor the liver enzyme in those patients, but it seems that liver or further liver damage is not higher than other people, which is about 10%. So that can happen in those patients. In really our case series, we have about 4 patients. 3 died within 2 months, but they died because of the hepatic failure, not because of the pulmonary hypertension. What we do in general, we start using sildenafil as the first-line treatment. But because those people goes very, very bad, we usually start talking with the hepatologists very early about liver transplant. Because if you wait until the pressure reach more than 45, that's too late. So whenever we need to start transplanting those patients, liver transplant, to cure both diseases, you have to do it when the pulmonary hypertension is very mild, which is pressure less than 35. Whether if you have somebody with advanced pH, that the pressure is high, and use drug for a while to drop the pressure and then send them for liver transplant is an option, we don't know. That's some center doing this, but Really, we don't know. So I think the message is try to pick them early, put them on treatment, which is usually sildenafil, and then we add bosentan if there is no problem with the liver enzyme. And we try to talk with the hepatologist or with the liver transplant surgeon to take them for surgery as soon as possible.
So Dr. Said Salim, تفضل.
Thank you, Professor Magdi. Every time I hear you, I feel really humble with an international figure like you. But my worry or concern about the cost benefit of these drugs, and what would be the fate of less expensive drugs like calcium channel blockers in such cases, and in what phase of is it phase 3, or you don't do animal experiments on such newer drugs?
Thank you very much. This is a very realistic question, that in a significant number of countries in the world, these drugs are not available. And I think it's not significant, it's the vast majority of the countries all over the world. These drugs are not available. Now, we have two good newses. Now, the first one, now both sildenafil and bosentan became generic. So now you already have two drugs that are reasonably cheap. Still, they're not very cheap, but they are reasonably cheap, that they are the sildenafil. I'm not sure how much it costs in Egypt, and bosentan. For example, bosentan in Saudi Arabia, 1 month supply of bosentan costs about 10,000 riyal, that's about 18,000 Egyptian pound. The generic bosentan costs about 900 riyals. So it's about 92% cheaper than the original bosentan. It is still a lot of money, but it is far cheaper. So I think with the availability of more generic drug, these drugs should be available to more people. But now we are trying to look at your question exactly, and now we are writing with the PVRI a global guidelines of how to treat pulmonary hypertension in financially challenging country. And how would you use, for example, calcium channel blocker in a country where right heart cath is not available? Because at the moment we're still saying calcium channel blocker should only be used if the right heart cath showed vasoreactivity. Because if you use it in non-vasoreactive patient, the patient die actually. And those are the 90% of the cases. So we try to make modification that if you have a patient in very early stage, that he is still the NYHO function class 2, the echo showed the right ventricle is not very dilated, no pericardial effusion, and the right heart cath is not available in your center, maybe it's justifiable in this condition to use a trial of calcium channel blocker. But keep in mind that you will be probably succeeding in 1 or 2 cases in every 10 patients. But that's better than really nothing. But if you start to use this drug, you have to monitor the patient carefully from hypotension.